Acute tubular necrosis, or ATN, is a type of kidney injury in which the tubular epithelial cells die as a result of either ischemia or exposure to toxic substances. It represents a form of intrarenal acute kidney injury, also known as AKI. Acute kidney injury in general describes a sudden and usually reversible loss of kidney function. It is defined by a fall in the glomerular filtration rate and therefore a rise in serum creatinine levels. According to the underlying mechanism, AKI is categorized into prerenal, postrenal, and intrarenal types. In prerenal AKI, the disturbance occurs before the kidney itself, meaning that blood supply to the kidney is reduced. Postrenal AKI results from obstruction of urinary outflow, such as by a kidney stone. At these stages, the kidney structure usually remains intact. In intrarenal AKI, the injury occurs within the kidney tissue, affecting the nephrons and the functional components. Acute tubular necrosis is the most common cause of intrarenal AKI. The difference between prerenal and intrarenal AKI lies mainly in the duration and severity of perfusion loss. In the prerenal form, the decrease in blood flow is still temporary. Tubular cells are stressed but remain viable. Urine output falls because filtration pressure in the glomeruli decreases. When the ischemia continues, oxygen levels in the kidney drop further. Tubular cells then undergo injury, detach from the basement membrane, and may form obstructive clumps inside the tubules. Urine production diminishes even more. At this point, the damage is structural and constitutes ischemic ATN. Despite cell death, regeneration of tubular epithelial cells is still possible when normal perfusion is initiated due to stem cells in the nephron. Therefore, the disease can resolve over time, though the recovery phase is usually longer than in purely prerenal injury. Ischemic ATN develops whenever prerenal extends into intrarenal AKI. So what causes hypoperfusion or hypotonia in the renal arteries in the first place? In myocardial infarction, for instance, cardiac pumping capacity may be inadequate, leading to low perfusion of organs. During shock states, such as sepsis or anaphylaxis, fluid shifts into peripheral tissues, leading to hypovolemia in the vessels and hypotension. Substantial blood loss from trauma or surgery can produce the same effect. The preferential involvement of tubular cells is explained by the differences in intrarenal oxygen supply. Even under physiological conditions, cortical areas containing glomeruli receive abundant blood flow, while medullary areas containing the tubular segments receive less. This arrangement preserves the kidney's osmotic gradient but renders tubular cells more vulnerable to ischemic injury. As a result, these cells are the first to be damaged when blood flow declines. ATN may also arise from toxic injury. The responsible substances are either exogenous, entering from outside the body, or endogenous, produced within the body. Among exogenous agents, certain medications are well known to cause tubular damage. Some antibiotics, for example, accumulate inside the nephron, where their concentration becomes much higher than in the bloodstream, and then can reach toxic levels. Another frequent cause is iodine, a contrast medium used for imaging. Toxic molecules naturally formed in the body can also damage the nephron when their levels become excessive. The most relevant are hemoglobin, myoglobin, and uric acid, also known as urate. In massive hemolysis, large amounts of hemoglobin are released from destroyed red blood cells. In rhabdomyolysis, the breakdown of skeletal muscle liberates myoglobin. Both contain iron, which promotes oxidative stress and tubular necrosis. Uric acid derived from purine metabolism may accumulate during tumor-lysis syndrome, when numerous tumor cells disintegrate. The resulting hyperuricemia can cause intratubular crystal formation and obstruction. The clinical picture of acute tubular necrosis varies with its cause. In ischemic forms, a preceding event such as myocardial infarction, surgery, trauma, or a severe infection, so sepsis, is often present. Pallor, low blood pressure, or signs of shock may be observed. Toxic forms tend to develop more insidiously, sometimes recognized only through declining kidney function tests. Regardless of cause, typical consequences include rising serum creatinine, fluid retention with edema, metabolic acidosis, and hyperkalemia. Characteristic laboratory patterns help identify ATN. The urine dipstick is usually bland, showing no blood or protein, because glomeruli remain unaffected. But keep the following in mind. The test for blood reacts to the molecule heme rather than to red blood cells themselves. It may therefore yield a positive result in rhabdomyolysis or hemolysis due to the presence of myoglobin or hemoglobin, which both contain heme, even without real erythrocytes being in the urine. Additionally, microscopic urine analysis often provides further evidence. Detached tubular epithelial cells aggregate with protein and debris to form casts. Under the microscope, these appear as muddy brown casts, a hallmark feature of acute tubular necrosis. Let's summarize. Acute tubular necrosis represents an intrarenal form of acute kidney injury resulting from either ischemia or toxic exposure. Ischemic ATN evolves from persistent prerenal hypoperfusion. Toxic ATN results from substances that become concentrated or reactive within the nephron. When tubular cells die, they may obstruct the lumen, further reducing glomerular filtration. Despite the damage, recovery is possible through cell regeneration, although the process requires time and supportive conditions. Dipsticks may be bland or positive for blood in hemolysis or rhabdomyolysis. Microscopy of urine shows muddy brown casts which contain dead renal epithelial cells clumped together. If you have any questions regarding today's topic, feel free to write a comment down below, or otherwise I see you next time.